You know that highly specific, slightly uncomfortable moment when you're sitting in an exam room?
Oh, yeah, just sitting there in the gown.
Right. And the crinkly tissue paper on the table is making entirely too much noise every time you shift.
It's the worst.
It really is. And you are trying your absolute hardest to describe a bizarre symptom to your doctor.
Like you're just searching for the right words.
Exactly. You find yourself grasping for words, and you end up saying something ridiculous like, it isn't a sharp pain. It feels more like a heavy vibrating badger is trying to dig its way out of my left shoulder.
A vibrating badger. I mean, we've all been there with those weird descriptions.
We have. And the professional sitting across from you just maintains this completely blank expression and, like, types something into their computer.
And you're left sitting there wondering how on earth they just transcribed vibrating badger into a permanent, legally binding medical record.
Right, because it is a uniquely vulnerable interaction.
It really is. I mean, you are handing over this messy, highly subjective, deeply personal physical experience, and they are tasked with immediately converting that raw data into empirical science.
Well, welcome to the Deep Dive. I'm your host, and today we are looking at the exact mechanism of how they pull that off.
And I'm your expert guide for this journey, and I have to say, our source material today is just incredible.
It really is a fascinating document. It's titled simply listeningcommonwords.pdf. And when you look closely at this text, it basically operates as a master vocabulary cheat sheet.
Yeah, it's designed to test or train medical professionals on their listening comprehension, specifically how to listen to us.
So our mission for this deep dive is to unpack this linguistic bridge. We're going to explore how these professionals are trained to decode the weird, wild, and just incredibly colloquial ways you and I actually describe our health, our bodies, and our lives.
It basically functions as a dual language corpus.
Right. And the first thing that hits you when you scan this document is the sheer, unadulterated whiplash of the vocabulary.
Absolutely.
Like, you are reading down this column of text, and you are forced to jump from a terrifyingly long clinical word like, wait, let me get this right, esophagogastroduodenoscopy.
Hey, that is a triumph of pronunciation on your part.
Thank you, I practiced. But you see that massive word right next to casual, everyday phrases like bum cheek or flabby arms and tummy tuck.
The contrast is completely stark. The proximity of high-level gastroenterology right next to bum cheek is so jarring.
It really is.
But it highlights the reality of the clinic, right? Bridging the gap between high-level medical science and everyday patient reality, it requires active, real-time translation.
Okay, let's unpack this. And my personal favorite highlighted example from the entire text, if a patient, quote, complained of breaking wind, the document literally maps that out as equals flatulence equals passing flatus or gases.
I mean, it establishes the fundamental baseline. A patient in distress isn't going to walk into an emergency room and state, Doctor, I am experiencing a painful accumulation of intestinal flatus.
Right, they're going to say they're breaking wind or they have gas.
Exactly. The listener has to catch the colloquialism, understand the underlying bacterial fermentation or whatever gastrointestinal mechanism it represents, and log the clinical equivalent without missing a single beat.
And this document treats that process like a high-stakes translation manual at the UN or something. It even has these bolded warnings about confusing similar-sounding words.
Which is where the stakes become incredibly apparent.
Yeah. It flags diseased versus deceased, as in died, and it flags terrible versus trouble.
That's our vital distinctions.
Right, I look at this and the logic is clear. Confusing diseased and deceased is a catastrophic failure of medical documentation. One means sick, one means dead.
Quite the difference.
Huge difference. But then the text explicitly warns the listener to distinguish between the word seller and the word sailor. And I got to push back here. That feels like we're straying away from pathology and into small talk. Like, unless I'm missing a massive clinical distinction between someone working retail and someone working on a boat, why does a listener need to actively distinguish between a seller and a sailor?
Well, what's fascinating here is that we tend to view the classic, what do you do for a living question as mere rapport building. Yeah.
Just a doctor trying to establish a friendly bedside manner.
But in a clinical environment, an occupation is not small talk. It is a highly specific data point used to calculate Bayesian probability for different diseases.
Oh, wow. So it's about mapping out environmental hazard zones.
Precisely. If a listener mishears seller, someone perhaps working indoors, standing at a cash register, prone to repetitive strain injuries or plantar fasciitis.
Yeah, right.
And instead documents sailor, which is someone out on the open water, the entire diagnostic algorithm shifts.
Really? Just from that?
Oh, absolutely. A sailor has prolonged UV exposure, altering their skin cancer risks. They are exposed to distinct maritime infections, totally different circadian rhythms, and historically different nutritional deficits like scurvy.
That makes so much sense.
Yeah.
And the document lists other specific jobs too, right? Like forklift driver, barrister, roof tiler.
Yeah, so if a patient complains of a slipped disc and the listener misses the fact that they said forklift driver, they miss the critical mechanism of the injury.
Right, they miss the fact that this person's spine is absorbing intense low-frequency vibrations for 10 hours a day.
Exactly. The occupation is the environment, and the environment provides the mechanism of disease. The language the patient uses to describe their daily routine is the first clue.
But the patient's vocabulary isn't just used to describe their job. The limits of language are really tested when patients have to articulate actual internal pain.
Oh, this is the point where the vocabulary sheet shifts from a standard dictionary into, like, a diagnostic telemetry manual.
It's so weird. It's almost like a bizarre wine tasting. Like, how do you identify the notes of a headache?
Because when clinical language breaks down, patients resort to vivid, almost dramatic metaphors.
Yeah, there is an incredibly detailed highlighted image text in our source, just dedicated to the subjective sounds people hear in their ears.
The ear sounds list is wild.
It is. The list includes, quote, blowing, roaring, buzzing, hissing, humming, whistling, crackling, bubbling, Rice Krispies, or sizzling sound in ear.
And every single one of those subjective descriptions correlates to a distinct physiological phenomenon.
See, I have to ask, does a doctor actually write down Rice Krispies in a chart? Isn't it a hindrance to use a subjective metaphor instead of a precise medical term?
You'd think so, but medical science relies heavily on pattern recognition. Those seemingly poetic metaphors are actually precise mechanical descriptors.
Okay, so how does something like Rice Krispies map mechanically?
Well, think about the physics of what makes a bowl of Rice Krispies pop. It's the sound of structural bonds breaking and surface tension shifting.
Okay.
In the human ear, if a patient describes that exact crackling, popping sound, the clinician is immediately picturing the eustachian tube.
Oh, wow.
Yeah, perhaps there is viscous fluid trapped in the middle ear from a resolving infection. Every time the patient swallows or shifts their jaw, the eustachian tube tries to open, and the sticky surface tension of that fluid breaks. It mechanically replicates the exact acoustic profile of popping cereal.
Wait, really? So the metaphor actually gives you the viscosity of the fluid?
It does. That is fascinating.
And meanwhile, a roaring or hissing sound points toward a completely different mechanism, often vascular.
Like blood flow. Right. It might be the sound of turbulent blood flow rushing through a narrowed carotid artery near the ear, or an inner ear pressure issue like Meniere's disease. The acoustic texture tells you if you're dealing with fluid mechanics or fluid dynamics.
And the document doesn't stop at auditory acoustics. It lists these intense physical sensations too, things like an impending sensation of death, a bullet in the head, a knotted sensation, a band-like pressure.
The descriptors are so intense.
They really are. It even includes visceral phrases like a fuzzy or floppy baby and a let-off leash or off-leash feeling.
Yeah.
Seeing impending sensation of death listed here next to colloquialisms like tummy tuck is just wild. Even knowing that a feeling of impending doom is a classic hallmark of a myocardial infarction, a heart attack.
It is, and the mechanism behind that metaphor is incredible. A feeling of impending doom isn't a psychological panic attack, it is a profound physiological response.
Yeah.
When a major cardiac event begins or blood pressure drops catastrophically, the body initiates a massive surge of catecholamines, adrenaline, and noradrenaline.
Oh, so it's a chemical flood.
A massive one. The sympathetic nervous system goes into absolute overdrive to keep the organs perfused. The body senses the systemic catastrophic failure at a chemical level before the conscious brain can even articulate what's wrong.
Wow.
So the brain translates that massive chemical surge into a psychological metaphor. I am going to die.
So the metaphor is literally just the brain's user interface for a chemical crisis.
Exactly. And the other descriptors operate the exact same way. If a patient describes a band-like pressure around their skull, the clinician visualizes the specific pericranial muscles tightening and spasming, a classic tension headache.
And if they say bullet in the head,
Or a sudden explosive thunderclap pain, the clinician immediately suspects a subarachnoid hemorrhage, a burst blood vessel flooding the space around the brain.
That's terrifying. And you mentioned a floppy baby.
Right. If a parent describes their infant as floppy, the listener isn't just noting a cute descriptor, they are instantly flagging hypotonia and opening up a massive, urgent diagnostic tree that ranges from severe genetic neuromuscular disorders to acute infant botulism.
But a patient's vocabulary isn't just spoken out loud, is it? Sometimes their physical movement and their broader life context are the things doing the talking.
Absolutely.
So if the spoken metaphors are the telemetry, the patient's physical movement and habitat are the structural foundation. Which brings us to the strangely specific categories of gaits and lifestyle choices in this document.
This section proves that medical listening extends far beyond hearing the words. It requires observing the physical context behind the words.
Here's where it gets really interesting. There is this highly technical highlighted list detailing specific walking styles. It lists stomping gait, scissoring gait, festinant or festinating gait, freezing gait, waddling or Trendelenburg gait, antalgic gait.
That's quite the list.
It is. Now, we all know an antalgic gait is going to confirm the severity of a localized injury, like a sprained ankle. But what fascinates me is seeing Trendelenburg gait mixed right alongside these jarring everyday domestic concepts.
Yeah, the transition is abrupt.
Right after the clinical gaits, the document lists mortgage, kindergarten, chores, dope smoker, jet lag, and competitive orienteering.
It reads like the raw output of a completely randomized word generator.
It totally does. I challenge this a bit, though. If I come in for a sprained ankle, why is my mortgage or my kid's kindergarten on the listening test? Like, the irony of grouping a hobby like competitive orienteering alongside Trendelenburg gait is just wild.
It forces you to view everyday domestic life as a literal medical hazard zone. A patient's health does not exist in a vacuum. It is a constant reaction to their ecosystem.
Okay, break that down for me.
Let's look at the mechanisms. When a patient casually mentions their child just started kindergarten, the listener's brain should instantly flag pediatric vector.
Oh, right. Kids are germ factories.
Exactly. A kindergarten is an epidemiological mixing bowl. It exposes the household to a constant rotation of fomites, head lice, and novel viral loads. The environment is the pathogen's entry point.
So kindergarten's essentially a high-risk exposure category. But what about the mortgage? How does a bank loan translate into a biological symptom?
Think about the physiological cascade of chronic psychosocial stress. The document includes symptom descriptors like weariness, lethargy, feeling rundown, and mood swings.
Okay.
If a patient presents with those symptoms, a doctor might immediately look for an endocrine issue, like hypothyroidism or an autoimmune flare-up. But if the listener hears the patient drop the detail that they just took out a massive mortgage, or they are drowning in chores, both terms from our source that changes the math.
Because the stress isn't just in their head, it's systemic.
Yes. The stress chronically activates the HPA axis, the hypothalamic pituitary adrenal axis. Their body is pumping out a continuous low-level stream of cortisol.
And that causes the weariness.
Over time, that hypercortisolism disrupts REM sleep, degrades immune function, and literally drains cellular energy reserves, creating that exact profound weariness. The mortgage isn't just a financial burden, it is the biochemical trigger for their physical exhaustion.
That is mind-blowing. And observing the gaits ties right back into this ecosystem approach, right?
Absolutely. If someone mentions they do competitive orienteering, which involves navigating treacherous, unpredictable, off-trail terrain,
Yeah.
and then they walk into the room with a severe antalgic gait, a pronounced limp, the clinician suddenly understands the exact biomechanical trauma the ankle endured. It wasn't a flat surface roll, it was a high-velocity, uneven terrain torsion.
So the clinician is building a three-dimensional model of the patient's physical and psychological reality using nothing but scattered conversational clues and visual observation.
Precisely.
Okay, so you've mapped the environmental hazards, you've decoded the dramatic telemetry of their symptoms, you've observed their physical context. The final step in this process is the intervention.
The phase where the medical professional actually attempts to alter the ecosystem they just decoded.
And this leads us directly to the document's chaotic inventory of treatments, pharmacology, and diet. Looking at this section is truly fascinating.
It's a lot of ticking.
It's like reaching into a medicine cabinet in the dark. On one side, you have this dense block of hardcore, highlighted pharmaceutical chemicals. Let me read this exact string. Hydrochlorothiazide, lisinopril, pravastatin, metoprolol, diltiazem, hydrocodone.
Yeah, that's a very heavy cocktail of cardiovascular interventions, diuretics, and narcotics. a standard pharmacological profile for a patient managing hypertension, hyperlipidemia, and chronic pain.
But sitting right next to those complex chemical names are the most mundane domestic terms imaginable. Things like butterroat, sponge bath.
Right.
The document points out Symbicort, which is butzenide, and formoterol, but explicitly notes that listeners should map that to the simple word inhalers.
To match what the patient will actually call it.
Exactly. And then, sitting all by itself, highlighted for emphasis, is the single word, halved.
Halved. That single word represents one of the most critical variables in modern medicine.
See, this is exactly what I wanted to ask you about. Amongst all the hydrochlorothiazides and the surgical terminology, why is a simple verb like halved so critical it gets its own focus?
Because it represents the reality of patient compliance. It's like a software engineer trying to debug a catastrophic system failure, running diagnostic after diagnostic on the code base, only to find out the user unplugged half the servers because the cooling fans were too loud.
Oh, man. So medical listening requires auditing what the patient is actually doing versus what they were instructed to do.
Exactly. It's about catching the unauthorized adjustments. Let's use the drugs on this list. Say a doctor prescribes lisinopril to lower blood pressure.
Okay.
The patient comes back and their pressure is still dangerously high. The clinical instinct might be to increase the dosage or stack it with hydrochlorothiazide. But if the professional is truly listening to the casual chatter, they might catch the patient mention that they halved their dose.
Because they had a side effect.
Yes. Because lisinopril works by dilating blood vessels. When the patient stands up quickly, that dilation causes a sudden drop in blood pressure, orthostatic hypotension. The brain temporarily lacks oxygen, which the patient describes using another colloquialism. They feel woozy.
Ah, so they hate feeling woozy and they just take a knife and cut the pill in half.
Exactly. They have it to avoid the side effect, neutralizing the treatment. If the listener doesn't catch the word halved, they might prescribe a massive overdose by piling on more drugs, not realizing the original drug was never fully in the patient's system.
Wow. Which turns the medical professional into a forensic accountant. You're auditing the patient's behavior.
You really are.
And the dietary terms in this document seem to play the exact same role. The list includes things like milky puddings, a little and often regime, and fizzy drinks. It also lists things you want to avoid, like a struvite stone, a specific type of kidney stone, and refined food. But how do milky puddings and fizzy drinks alter the pharmacology?
Well, they alter the biochemical environment the drugs are trying to operate in.
Oh, I see.
If a patient is prescribed metoprolol, or a specialized medication for acid reflux, but they casually mention they've been surviving on a little and often regime of fizzy drinks to settle their stomach.
Which people do all the time.
All the time. Or they're eating bowls of milky puddings. Those aren't just snacks. Dairy can heavily bind to certain antibiotics, completely blocking their absorption in the gut.
Really? Just from pudding?
Just from pudding. And the carbonation and sugar in fizzy drinks actively alter the gastric pH, which can degrade medications before they hit the bloodstream and exacerbate the exact acid reflux the doctor is trying to cure.
So the diet is actively fighting the prescription.
You can prescribe all the advanced chemical interventions in the world, but if the patient is chugging fizzy drinks and having their pills because they feel woozy, the treatment fails.
Right.
The listener has to catch the halved pill and the milky pudding to actually have a chance at healing the patient.
When we step back and look at the totality of this document, from the explicit translation pairs to the pharmacology, it completely shifts how you view the person sitting across from you in the clinic.
It really changes the perspective.
We've traced the journey from decoding breaking wind and bum cheeks through interpreting the acoustic telemetry of Rice Krispies in an ear, all the way to understanding how a mortgage physiologically alters the body.
It reveals that medical professionals cannot simply be pure scientists crunching lab numbers. They have to be elite linguistic detectives.
Yeah.
They are taking the messy, poetic, highly subjective, and often irrational reality of human life and reverse engineering it into a framework that can actually stabilize a biological system.
It is a staggering cognitive load.
Unbelievable.
And it guarantees that the next time you, our listener, are sitting in that exam room and you describe a cough as barking, or a headache is a tight band, or you casually drop that you've been dealing with a lot of chores since your kid started kindergarten, you aren't just making small talk to fill the awkward silence.
Not at all.
You are feeding vital, highly specific data into a calibrated listening machine. Every single metaphor is a diagnostic clue.
Which leaves us with one incredibly fascinating dynamic to consider.
Oh, what's that?
Well, if medical professionals require this extensive, deeply complex cheat sheet just to decode the strange, colloquial ways that we patients describe our own physical reality, what would a reverse cheat sheet look like for patients?
Oh, wow.
Yeah, trying to decipher the hidden meanings, the curated phrasing, and the carefully constructed bedside manner that doctors use when they talk to us.
That is a brilliant thought. We'll leave it right there.